Hello, sports medicine students, and welcome to my kitchen for the first day of the anatomy of the knee and knee injury notes. This will be part one. There'll be several parts in this. We're trying to chunk them into about 20-minute lectures. I would use a split screen if I were you and put your notes on one side, and then on the other side, you can have the presentation that I'm sharing here. We're going to start out with anatomy of the knee. The knee is the largest and most complex joint of the human body. There are four bones that make up the knee joint. We have the femur, we have the tibia, the fibula, and the patella. So here we have the femur, the tibia, the fibula, and the patella are the four bones that make up the knee joint. One part of the joint is the tibiofemoral joint. The tibia is here, where the tibia and the tibial plateau, right here where you can see the red and purple menisci sitting on top of the tibia plateau. And then we have the femur here. We have medial and lateral condyles of the femur. This is the tibiofemoral joint. The next we'll talk about is the patellofemoral joint. The patella is here, which remember is a sesamoid bone, and the femur is the long bone of the upper leg. You can see the medial condyle and the lateral condyle there as well, and the trochlear groove. The trochlear groove is the groove the patella slides on. The patella gives a mechanical advantage to extending the knee, and it increases the quadricep force by 33 to 50%. The next part is articular cartilage. Articular cartilage is a thin layer of connective tissue that covers the ends of all of our long bones. We have articular cartilage on our femur, and then this is a picture of the tibial plateau where there's articular cartilage. In addition to articular cartilage, one type is the meniscus. You have a meniscus, you have a medial and you have a lateral meniscus. You can see them here. They are the red or the pink here. This is the fibula out here. So this is the medial meniscus, and this is the lateral meniscus. The meniscus are wedge-shaped for greater stability. The menisci aid in shock absorption, distributing forces, and improving the stability of your knee. The medial meniscus, between the medial femoral condyle and the medial tibial plateau, as we talked about right here, is your medial meniscus. This is your lateral meniscus, which is between your lateral femoral condyle and your lateral tibial plateau. Now talking about ligaments of the knee, there are four main ligaments of the knee that we will talk about. We will talk about the medial collateral ligament, the lateral collateral ligament, the ACL, the anterior cruciate ligament, and the PCL, the posterior cruciate ligament. On this slide, the medial collateral ligament, or the MCL, is actually outside of the joint capsule. It attaches the femur to the tibia, and it provides medial stability right here. The LCL, the lateral collateral ligament, is outside the joint capsule and attaches the femur and the head to the fibula. It provides lateral stability. You can see the lateral or the LCL here. The next two are ACL and PCL. The ACL is within the joint capsule and attaches the femur and anterior aspect of the tibial plateau, which restricts anterior movement of the tibia. Keeps the tibia from moving forward here, and you'll see that when we talk about ACL injuries and how we test for that. So the ACL can be seen right here. The PCL is right back here, or posterior cruciate ligament, is within the joint capsule as well, and it attaches the femur and the posterior aspect of the tibial plateau, which resists posterior movement of the tibia on the femur. So the tibia is here, the femur is here. It keeps the tibia from moving back. Next thing we'll talk about are the muscles. The two main muscles that we'll talk about on the upper leg are the quadriceps. The quadriceps consists of the vastus medialis oblique. We call that the VMO. This muscle right here. The next one is vastus lateralis, which is on the lateral side. And then we have the vastus intermedialis, which will be right here. There is a fourth muscle because quadricep, remember quad is four. The rectus femoris is the deepest of the four quad muscles. All the quad muscles aid in extension of the lower leg, knee extension. The hamstrings are on the back of the upper leg. There are three muscles of the hamstring. We have the semitendinosus, the semimembranosus, and the bicep femoris. All of these muscles that make the hamstrings aid in flexion of the knee. knee flexion. Now we're going to talk about injuries, injuries to the knee. There we go. The first injury I'd like to talk about, which is a common injury, it's called the terrible triad, or it's an MCL tear, a meniscus tear, and an ACL tear. Those three things together are called the terrible triad, or O'Donoghue's triangle. Let's look at them individually. The first one we will look at is an MCL sprain or an MCL tear. An MCL sprain is medial collateral ligament. This is stretching, or it could be complete tearing of the MCL, or the medial collateral ligament. There's going to be pain, tenderness on the medial aspect of the knee, as you can see right here where this is torn on the inside of the knee. There will be pain right there along the joint line. You'll have difficulty bearing weight with a grade 2 or 3, where we've talked about 1, 2, and 3 grade sprains. You will have limited range of motion. There will most likely be swelling on the inside of the knee. Treatment for an MCLs do typically repair themselves with rest, ice compression, and elevation unless it is completely torn. MCL testing. They do a valgus, athletic trainer or the orthopedic doctor will do a valgus stress test, and we're going to watch this valgus stress test to see how they do that.
In this video, I'm going to demonstrate the valgus stress test. Now, with your patient in supine position, instruct him to relax as much as possible during the test. With one hand, grab onto the lower leg just above the ankle joint, and the other hand is used to fixate the femur. Then, slightly externally rotate the tibia and perform passive abduction in the knee joint, thus putting stress on the medial collateral ligament. You're looking for
the stress is
excessive
right here
gapping on the medial side and the reproduction of pain.
If your MCL is intact, you're not going to get that movement.
Consequently, perform the same test with the knee in 20 to...
They would also do the same test, that same thing that he just did, with 20 to 30 degrees of flexion.
30 degrees of flexion. Again, you're looking for excessive gapping on the medial side.
The gapping would be right here. They would be able to see that. That is an MCL strain or MCL tear. The next one, the next part of the terrible triad, is a meniscus tear. The meniscus, remember, are those shock absorbers. You have a medial and lateral meniscus that are found inside the joint here. This is the medial, sits on the medial tibial plateau, and the lateral sits on the lateral tibial plateau. The meniscus are often torn when your knee is twisted suddenly, and the meniscus is trapped between the femur and the tibia here. Some red flags to watch for if somebody may have a meniscus tear would be swelling, pain, popping sound, locking, giving way of the knee. There's 2 tests to test for meniscus tears. Let's look at what those 2 tests are. If we were in the training room, if we were in class, we would be able to try these on a friend. If you have a sibling, you could try this. Or you could try this test on your own.
On the Tessely test for meniscus lesions. This means that the Tessely test is not in this regard. So when you speak before you move on to the injured leg. To perform this test, have your patient stand on the injured leg, which is flexed to 20 degrees. Your patient may hold on to your arms for support. Then rotate over the tibia 3 times on each side.
That looks painful.
Okay. This test is positive if your patient
that is a
complaining about
test.
pain in the joint line during the rotations.
The second one is the McMurray test.
This is going to be a video on the McMurray's test for meniscal damage.
All right, we'll fast forward through this.
This test, have your patient in supine lying position with the tested knee fully flexed.
Remember supinate.
Then rotate the tibia medially and bring the knee into extension.
This is very painful if you have a
want to
meniscus
repeat
tear.
this process a couple of times with a different angle of knee flexion in order to test the whole posterior aspect of the lateral meniscus. In order to test the medial meniscus,
so you can see, I'll pause this here, as he was pushing out, he was pushing towards the middle there. It was putting pressure on the lateral meniscus. Now he's going to do the opposite. He's going to test the medial meniscus, which will be on the inside.
The tibia.
That is the McMurray
test. The anterior
test.
half of the meniscus is not as easily tested with the McMurray test because the pressure on the meniscus is not as high. This test is considered positive if your patient experiences clicking, locking, or pain in the knee. All right, guys.
All right, so that is, we've gone through MCL testing, we've gone through meniscus testing. There are many different types of meniscus tears. You can see here is a vertical longitudinal tear, which is kind of in the middle of the meniscus. There is a vertical radial tear, which goes into the middle of the meniscus, a horizontal tear, an oblique tear that kind of slides in here, and a complete or a degenerative tear here. Oftentimes as people get older, their meniscus get more worn out, their shock absorbers get worn out. There's these degenerative tears, and maybe no one impact happened, but over time, the meniscus just degrades. Meniscus tear treatment, there's an example here of meniscus tear. What they can do with the meniscus tear, they can either fix it, they can repair it with sutures, or they can cut it out. So this is an example of a meniscus meniscectomy is what it's called, where they just kind of snip out a little piece of the meniscus and then you should be able to go off on your way. You won't have to be on crutches for any extended period of time. A repair was actually where they would use sutures to sew the meniscus back together, and you would be on crutches for probably about 6 weeks after that. Another kind is a bucket handle tear, fairly common meniscus tear, and they can try to suture this back together, or they could trim the meniscus here. You're going to lose a lot of your meniscus if they do a meniscectomy on this bucket handle tear. A bucket handle tear, it can shred and kind of destroy the meniscus. That's something that I experienced when I had my soccer injury. Anterior and posterior root tears. A root tear is where the meniscus, you can see the meniscus here and here. These are the root attachments. This is the anterior root attachment, and this is the posterior root attachment of the medial meniscus. And the same thing, here's the lateral. We have a posterior attachment, and then here we have an anterior attachment. The roots allow the meniscus to, if you have a root tear, this allows the meniscus to slide outside of the joint. And here's a picture of an MRI that I had last December, and you can see this triangular wedge. The black wedge is my meniscus, and here's the joint. So the meniscus is sitting outside of the joint in that case. In my case, that's not good because the femur is coming in direct contact with the tibia and causes articular cartilage damage right here on the femur and the top of the tibial plateau there. So the meniscus is this triangular shape. We'll see probably some better looking menisci MRI images later. This can lead to rapid development of articular cartilage lesions on the femur and tibia. Meniscus tear treatment. There are 3 things, as mentioned earlier. The doctors can repair it, and that would look like this. Meniscus repaired with sutures, and they literally just go in and they sew it back together. Here's the tear. They're going to sew it back together. The second thing they can do is that they can snip that part of the meniscus out. And then the third thing, if that doesn't work, if you have a subtotal or total meniscectomy, then they can do a meniscus transplant. There's a little picture of me. I said I've tried all of these and I haven't found one that works as good as my native meniscus. So if you can keep your meniscus, the better off that you're going to be. We're going to watch, I believe this is a meniscectomy.
Meniscus tears are sometimes repairable. The outer rim of the meniscus has a better blood supply. This is known as the red zone. The inner part of the meniscus has very little blood supply. It is known as the white zone. The red-white zone is in between. The farther into the red zone the tear is, the more likely it can be repaired. Meniscus repairs are often done arthroscopically, meaning that they are done using a scope rather than by making a larger incision. Once the sterile water is flowing
Scope
into
is
the
an
knee and the
arthroscope,
tear is well
called
visualized
an
with the camera,
arthroscopic surgery.
special instruments are used to pass suturing thread into the joint. The special instruments are then used to sew up the torn part of the meniscus. It is best to repair the meniscus if it is repairable to keep as much shock absorber as possible in the joint. When the meniscus is repaired, the repair must be protected by not walking on the knee until it has had time to heal. This means
That's
a
the
few
6
weeks
weeks
on crutches.
that we talked about.
A person who has a meniscus repair should work on gentle range of motion to prevent the knee from becoming stiff.
All right, so that's
If
what a
the blood
meniscus
supply to the
repair
torn part of the meniscus
looks
is
like.
poor, attempting to repair the tear is useless. This is because the nutrients needed for healing cannot reach the tear. While
Because there's no
stitches
blood
might hold
supply.
the torn edges in place, the edges will never heal back together. Only the outer edge of the meniscus has enough blood supply for a successful repair. When a meniscus tear is not repairable, the torn portion of the meniscus is shaved away. This results in a smoother edge that does not catch or cause pain. While it is good to leave as much healthy meniscus as possible, it is better to remove the torn portion as it can continue to catch, cause pain, and wear away at the articular cartilage. This procedure is known as a partial meniscectomy.
All right, so those are the 3 options with the meniscus tear treatment. They can repair, they can do a meniscectomy, which is an excision or taking out part of the meniscus, and then after they've tried these 2, a meniscus transplant may be a 3rd option for a young patient that is active and continues to have medial lateral sided pain due to the lack of meniscus. Meniscus transplant, let's talk about that for just a little bit. I think I've told you guys in class I had a meniscus transplant last May that didn't go very well for me and failed. And as you guys know, I had surgery again in January to try to repair that meniscus transplant. A transplant of a cadaver, medial or lateral meniscus using bone plugs and sutures. So this is an example of, this is a medial meniscus transplant here. You can see that there's 2 bone plugs. So from the cadaver, they've cut off the meniscus from the tibial plateau, and they've taken 2 pieces of bone from the tibia that they're going to drill 2 holes in the recipient's knee into the tibial plateau, and they're going to pull down, this is called transtibial, so it's going through the tibia to lock those 2 bones in place to keep the meniscus here. Then the meniscus will heal back into the recipient's medial plateau here. This is a salvage procedure used when the meniscus has previously been removed due to injury. This is often combined with other procedures. When I had my meniscus transplant, they did an anterior lateral ligament, which was on the outside here, and they also did an ACL revision. So they can do multiple surgeries together to help correct knee instability. Meniscus transplant may be an option for young active patients, as I talked about, with little articular cartilage damage. If there is damage to this tibial plateau,